Next, we're going to talk about an exciting drug class, the GLP-1 agonists. They all end in tide. So things like exenatide, liraglutide, dulaglutide, some have also the glue in their name, which also can remind you that these are drugs that we use to treat diabetes. So until recently, they were only available subcute, and some of them were available to take daily. And then there's also weekly formulations. These are those guys that are also available to just inject once a week. Now we have actually also oral available tides, and this is semaglutide. And this makes this drug class even more attractive because they're not just anymore injectables. They are also oral medications. So let's first think about how do these GLP-1 agonists work. And to understand their mechanism of action, let's think about what does GLP-1 in our body do? Well, first of all, where does it come from? It is released from the terminal ileum in response to nutrients. That means it is made when you had a meal and also ate a lot because nutrients reach the terminal ileum. So that's where it's coming from in response to the nutrients. And what does it then do? Well, we want to now produce insulin because we just had a meal. That's number one. And there is a GLP-1 receptor on the pancreatic beta cell. So it's a GS coupled receptor. So it's going to increase cyclic AMP, it's going to increase pKa, and then it's going to phosphorylate this calcium channel here. So that's where calcium comes in. And calcium triggers insulin release. So here are these vesicles in the pancreatic beta cell that contain the insulin, and upon stimulation of these receptors, they're going to help this calcium channel to open better, and then the calcium triggers the exocytosis, and then insulin is released. Now I just want to point out what they really do is they trigger glucose-dependent insulin release. That means if there's no glucose around, so if these pancreatic beta cells are not gonna sense any glucose, and you know this is this GLU2 here, then this mechanism would not work. So what they really do is, once you stimulate the GLP-1 receptor, they help open the calcium channel better. But this doesn't work independent of glucose. So you have to have food and you have to have glucose. And then you're going to get more insulin release. What else is going to happen? Well, they're also going to have effects on the stomach, because we just said they are released upon nutrients reaching the ileum. So what do we want to signal our stomach? Well, slow down gastric emptying, because not everything got digested and we had a big meal. So we want to slow down gastric emptying, make sure that the stomach can fulfill its job, break down the food, and then there's enough time for the intestine to work on it and to absorb the nutrients. So gastric emptying will be slowed down. And then also they have effects on the brain to decrease appetite. It's also time to eat less, decrease appetite, because nutrients even reach the ileum. So what you can see clearly here is that this drug class has a lot of different effects, because obviously these GLP-1 agonists, and we can just put them in here, so GLP-1 agonists, they do the same as a GLP-1, are going to have a lot of different functions. And this is in contrast to other medications that we discuss for the treatment of diabetes, where there's usually one target, the pancreatic beta cell. We're also going to talk about one that acts in the kidney. But here you can see there's a lot of actions. They're going to help release insulin. They're going to decrease appetite. They also decrease gastric emptying. And you may know that these drugs are also approved for the treatment of obesity and obviously type 2 diabetes. So they have more indications due to many of their effects. So here's just in writing again what they do. They act at the GLP-1 receptor in the beta cell. They help getting us out more insulin. So this promotes glucose-mediated insulin secretion. And then in the stomach, they slow down gastric emptying, and they also decrease satiety, decrease appetite, and that's a central effect. So let's next talk about their therapeutic effects. So we first want to think about how much do they lower A1C, and they are highly efficacious. So they lower A1C more than 1.5%. So they're in the category of high efficacy. They don't have any risk of hypoglycemia, which is very good, obviously, because they just help us in a glucose-dependent fashion to get us out more insulin from the pancreatic beta cell. What about weight? Well, they're also approved as obesity drugs. So with their mechanisms on slowing down gastric emptying, which is not gonna have you eat a lot more because your gastric emptying is already slowed down, and also decreasing appetite as a central effect, they are very good in also losing weight. Now they have another very big advantage. Studies have shown that they reduce cardiovascular risks. So cardiovascular risk reduction, and even have renal benefits. So this makes them really a drug class that are highly efficacious and have all these other good things, where we can really talk almost about an ideal drug with all these other benefits. Now this is not a class effect. It has not been shown for all of the GLP-1 agonists, but for many of them, definitively the one that I have written up here, and also liraglutide. So lots of them have already shown in trials that they have very beneficial effects on the cardiovascular system and also renal benefits. So because of their cardiovascular risk reduction and their renal benefits, obviously they are ideal drugs for patients with diabetes, because these are the patients that a lot of times have also cardiovascular risk factors and renal disease. So let's get to the adverse effect of this drug class. The most common adverse effect is GI effect. So let's write here most common. So you can imagine, I mean, these drugs slow gastric emptying. So that means whatever you eat is going to sit forever in your stomach. So you may feel full, early satiety, nauseous. That's very common for this drug class. Obviously, weight loss is another effect. There's also an increased risk of pancreatitis. Also, there's important contraindications, so you should always check for a family history of medullary thyroid carcinoma, or if a patient has it, also another endocrine systems tumor, this medullary endocrine neoplasia type 2. Studies in rats have shown these tumors develop in rats. So as of caution, it's also not given to any patients with a history or having these tumors. Next, I want to talk about the dual agonists. So there are newer drugs that are GLP-1 GIP receptor agonists. And so this other, so we already talked about GLP-1, but there's also GIP-1, which is another incretin. It has very, in part, similar functions like GLP-1. It just seems to generally more concentrate on the pancreatic beta cell to really improve insulin secretion, and a little bit less effect on the other things that we discussed. But these are highly efficacious drugs. Our example here is, there's only one on the market so far, tirzepatide. So as it relates to the therapeutic effects, these dual agonists are the most efficacious drugs that we have right now. They will lower A1C 2 to 2.5%. So we can call them, this is highest efficacy. So they're the best right now. Also no hypoglycemia, because they just promote glucose-dependent insulin release. They are even better with weight loss compared to the GLP-1 agonists that make people lose weight even more. And they also show cardiovascular risk reduction and renal benefits. So this is tirzepatide. As it relates to the adverse effects and contraindication, so it's very similar to what we discussed for the GLP-1 agonists.